Good afternoon. I'm Stephanie Q, and one of the presenters from my group today. Our topic is antimicrobial resistance in dental practice in Malaysia during the pandemic. Antibiotics are the medicines used to prevent and treat bacterial infections. However, the antibiotic resistance that occurs when the bacteria change in response to the use of these medicines can lead to higher medical costs, prolonged treatment, and increased mortality. So what is antibiotic resistance? It occurs when the microorganisms such as bacteria, fungi, develop the ability to defeat the drugs designed to kill them. That means the microorganisms are not killed, but they are growing continuously. The infections caused by the antibiotic-resistant microorganism are difficult to treat, and sometimes they are untreatable. In most cases, the antibiotic-resistant infections require extended hospital stays, additional follow-up doctor visits, and costly and toxic alternatives. The antibiotic resistance does not mean the body is becoming resistant to the antibiotics, but it is that the bacteria have become resistant to the antibiotics designed to kill them. So it is a general term for many types of resistance, such as antiviral, antibacterial, antiparasitic, and antifungal drugs. So next, what is COVID-19? The ongoing global pandemic of coronavirus disease is an infectious disease caused by a newly discovered severe acute respiratory syndrome coronavirus 2. The symptoms range from asymptomatic to life-threatening. Most people infected with the COVID-19 virus will experience mild to moderate respiratory illness and recover without requiring special treatment. However, the older people and those with underlying medical problems like cardiovascular disease, diabetes, chronic respiratory disease, and cancer are more likely to develop the serious illness. The COVID-19 virus spreads primarily through the droplets of saliva or discharge from the nose when an infected person coughs or sneezes, so it's important to practice respiratory etiquette. So that dental infections, including the periodontal disease and the dental caries, are the chronic infective dental diseases caused by the microorganism living in the oral cavity. These oral microbiomes present in the saliva as a free-floating microorganisms and form a complex ecological community of biofilm attaching to different surfaces of the mouth cavity. When the bacteria gets into the root of a tooth, it can cause a build-up of pus. This kind of infections is called a periapical abscess. So the common microorganisms that involve in the dental infections are the streptococcal gram-positive bacteria, which also known as the viridans streptococci, was responsible for the dental alveolar infections, periodontitis, and pericoronitis. Next are the Fusobacterium, Peptostreptococcus microbes, Prophyromonas species, and Prevotella species are also responsible for the dental alveolar infection. And lastly, they are the Peptostreptococcus microbes, which also identified by another group of researchers as responsible for the progressive periodontitis. Other studies reported that 90% of root canal infections were due to the obligatory anaerobic microbes. So next, we will see into the antibiotics that are commonly used in dentistry. They are the beta-lactamase, the nitroimidazole, the lincosamide, the macrolides, fluoroquinolone, and the tetracycline. The beta-lactam antibiotics are the antimicrobial agents that contain beta-lactam ring in their molecular structure. This group of antibiotics is a bactericidal agent that act against the many gram-positive, gram-negative, and anaerobic bacteria via inhibiting the synthesis of the cell wall. The beta-lactam antibiotics are categorized into 5 classes: the penicillin, the cephalosporin, penums, carbapenems, and monobactams. The overuse and misuse of the penicillin and cephalosporin has resulted in an increased rate of bacterial resistance, caused by the production of beta-lactamase. Moreover, the risk of resistance might be increased if the penicillin is administered simultaneously with other antibiotics, for instance, the metronidazole. The allergic reactions caused by the release of the immunoglobulin E, the mediators, are among the common side effects of beta-lactams and might include the rashes, pruritus, and also even the anaphylactic shock. And next will be the nitroimidazole. They are commonly administered to treat parasitic and anaerobic bacterial infections. They include the metronidazole, the nimorazole, and tinidazole. It has been noticed that dental practitioners tend to prescribe metronidazole for the treatment of acute infection, as it has great anti-anaerobic bacterial activity and low risk of toxicity. So that's all from me. I will now pass to my group mates to continue the presentation.
Hi, my name is Che Yi-Hui, and I will be continuing about the antibiotics commonly used in dentistry. The first one would be the macrolides, in which they have a macrocyclic lactone ring, which are bacteriostatic agents that inhibit the protein synthesis. They have translation modulators that act against the bacterial ribosomes. Macrolides mainly act against the beta-hemolytic streptococci. And it should not be co-administered with clindamycin since they have the same target point and antagonistic effects. Moreover, the macrolides should not be prescribed in patients with progressive cirrhosis, as this could result in the liver failure and even death. Next one would be the lincosamide, in which they are also bacteriostatic agents that mostly fight against the gram-positive and aerobic pathogens by binding to the functional spot of the bacterial ribosome, and it restricts the protein synthesis. Lincomycin and clindamycin are the drugs that are classified in the group of lincosamide antibiotics. Studies show that clindamycin has a greater effect against the infections compared with other lincomycin. The co-administration of lincomycin and erythromycin is not suggested, as these two drugs have an antagonistic effect against each other, while among other lincosamides, the prescription of clindamycin is more common than the others. Moving on to the next slide, we will be talking about the fluoroquinolones. It is a broad-spectrum bactericidal antibiotics that mostly act against the gram-negative bacilli, gram-positive aerobic cocci, and anaerobic organisms by preventing the synthesis of DNA. It is commonly prescribed for the non-odontogenic infections, such as the respiratory, genitourinary tract, joint, and bone infections. These agents have a higher capacity of penetration into the tissue in comparison with other commonly prescribed antibiotics in the dental practice. The side effects of the fluoroquinolones include the GIT reactions and cartilage, joint, tendon, and the central nervous system involvement. It must not be prescribed for children because of the possibility of chondrotoxicity in the developing cartilage, and for patients who use theophylline, as this could result in serious complications, for example, the seizures. Tetracycline is a bacteriostatic antibiotic that is active against the gram-positive and gram-negative bacteria. It acts by blocking the synthesis of protein through binding to the ribosomal subunit. It is a drug which could be a reasonable prescription for the treatment of periodontal disease, as it has anti-inflammatory activity, collagenase inhibition potential, and bone resorption inhibitory capacity. It could help the fibroblasts to attach to the root surface, improving marginal attachment, and enhance the bone graft. The drug has a long half-life, which preserves its antimicrobial activity for a long time. However, the agent is not commonly suggested for the treatment of odontogenic infections because of the widespread resistance of pathogens and several side effects, including photosensitivity, nausea, vomiting, diarrhea, loss of appetite, hepatotoxicity, and discoloration of the primary and permanent teeth. The prescription of the drug for young children and pregnant women would not be recommended because it can cause intrinsic tooth staining during the calcification phase, and tetracycline must not be prescribed for the patients with active liver disease. We will now be moving on to the indications of the antibiotics. The first one would be the treatment to odontogenic infections, treatment of non-odontogenic infections, prevention of focal infection, and the prevention of local infection. The next slide will be about a graph, which is two graphs which talk about the relationship between the antimicrobial resistance and COVID-19. In the graph one, which is the left side, it states that before the coronavirus 2019, which is also known as COVID-19 pandemic began, antimicrobial resistant AMR was among the top priorities for the global public health. The amount of antibiotics used in both ICU and hospital wards in Malaysia has increases. The outbreak of COVID-19 and the resultant restriction on the dental services across Malaysia created new and difficult challenges for dentists. The first lockdown and the closure of dental surgeries caused major disruption to the patient care. It took time for SOP to be issued, and all units were all under significant pressure, trying to do what was the best for the patients in stressful and uncertain circumstances. It was predicted that we did see a major increase in the amount of antibiotics being prescribed during this period, and now we have figures and graphs which confirm it. A data which is collected in England states that antibiotic use in May 2020, which is shown at the second graph at the right side, was 18.4% higher than in May 2019. And the antibiotic prescribed in England reached at a peak in the June. 25% more prescriptions for antibiotics were issued between April and July 2020 than in the same period last year. There are many understandable reasons why this increase may have occurred. Dentists may have felt pressure by some patients for antibiotics, or they may have had difficulties diagnosing a patient's condition remotely and so adopted a better safe than sorry approach. Both dentists and patients may have also been seeking to avoid an unnecessary extraction in the hope that dental clinics might soon return to their general dental practices, and dentists may have felt pressure by some patients which required to have tried antibiotics before accepting a referral for face-to-face care. So that's all from me, and I will be passing on the presentation to my groupmates. Thank you.
Good afternoon, I'm Chiu Ji-shan, and I will continue with the dentist's role to reduce antimicrobial resistance. Like other health professionals, dentists share responsibility in the coordinated global action plan to minimize the emergence and spread of AMR. A multidisciplinary approach is necessary for establishing an effective antimicrobial stewardship in all clinical settings, understanding the relevance of optimizing the indication, selection, dosing, route of administration, and duration of antimicrobial therapy. It is mandatory that the antimicrobial drug prescribed to dental patients are well justified and always considering the clinical situation for each individual. For example, in some populations, such as aging population, are identified as having a high burden of infection resulting in subsequent higher antibiotic use or misuse. Dentists should improve antimicrobial prescribing practice in an effort to restrain in increasing incidence of antimicrobial resistance and other side effects of antimicrobial drug abuse. Next. There are 3 specific actions proposed for dentists and their teams. First, stop and think before prescribing antibiotic drugs. Will this drug really help the patient condition? Is the diagnosis of the patient condition clear? Could an operative intervention such as abscess drainage endodontic access, periodontal cartilage, restorative treatment, etc. be conducted instead of prescribing antibiotics. The second point is keep up to date. Use updated standardized guidelines to prescribe any drug, especially antibiotics. Dental association, universities, and continuous education providers should offer these guidelines and strengthen action to ensure adequate training for all dental students and professionals in the diagnosis of the cause of and treatment planning for acute dental pain. Next, educate the dental patient. Establishing good communication with the patient is needed in order to better explain the importance of following the dentist's instruction when taking antibiotics. Also, patients must be aware of treatment options if they are in dental pain and that taking antibiotic is not always ideal. Self-prescribing and drug sharing are practices that should be discouraged among patients. Next. Antibiotic stewardship is a coherent set of actions which promote appropriate use of antibiotic, example in ways that ensures sustainable access to effective therapy for all who need them. We can combat antibiotic resistance by preventing tooth decay. This is because when there is less tooth decay, it will be less infection, so less antibiotic is used. As a result, antibiotic resistance can be reduced. Next. Antimicrobial susceptibility test. The microbial sensitivity test may be utilized whenever an acute dental infection is being treated or a resistant strain of organism is suspected during antibiotic therapy. The dentist need only obtain a sample of exudate or purulent material from the infected area and send it in a culture tube to a diagnostic laboratory for determination of the organism type and its antibiotic sensitivity. From the result of the test, the antibiotic of choice can be administered to combat the infection and prevent the development of resistant organism strains. Next. In conclusion, everyone is vulnerable to antimicrobial resistance and everyone has a role in tackling it. National Dental Association are responsible for advocating for dentistry within NAPS and driving forward dental antimicrobial stewardship initiative. Organizations providing dental care are responsible for creating an environment conducive to appropriate management of patients. We are all responsible for using antibiotics only when necessary. Next. Here is our reference and this end of our presentation. Thank you.